That is alarming to me, and I know that that's how people sell AI for the return on the investment because of the more productivity you can squeeze out of the provider base. I'm a little jaded right now, and we'll have to wait and see how that happens.
So are you saying that you're reluctant to change?
I am a little reluctant to change, but only a little. I'm in that slight denial, soon to accept category. Hello, and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I am your host, Lee Scheinbart, and this podcast brings you stories and wisdom from some of the best leaders in healthcare today, with a focus on the role of the Chief Medical Officer and physician leadership. Today, it's my honor to introduce Dr. Stuart Marcus, Professor of Medical Education and Chair of the Department of Clinical Sciences at Nova Southeastern Dr. Kiran Patel School of Allopathic Medicine. Wow, that's a mouthful. Dr. Marcus initially grew up in Brooklyn, New York, but experienced his teenage years across the river in New Jersey before later earning his undergraduate degree from Rutgers. Dr. Marcus next earned his medical degree at Duke University and entered his surgical residency at NYU's School of Medicine and completed his medical training with a fellowship in surgical oncology at the National Cancer Institute. Finally, Dr. Marcus holds an MBA from UMass Amherst. Stu, welcome to the show.
Lee, it's a pleasure to be here. And you're right, the school is a mouthful, so we like to call it NSUMD for short.
that doesn't roll off the tongue too easily. That takes practice.
You get used to it. NSUMD, give it a try.
Got it. Well, I imagine that our listeners are probably thinking, based on that biography, why exactly is Dr. Marcus on the podcast? And perhaps you yourself are beginning to ask the same question.
Yeah. Well, I'm here. You invited me here, and I'm happy to oblige. And I think there's a lot happening with physician leadership, medical education, the whole field of healthcare these days sometimes feels like it's on fire. So it is certainly worth being here to share things with your viewers.
That's perfect. That's why we call it the Fire Chief Podcast, and we'll get into that in a little bit. We have a couple of things in common. The first is that we both served as chief medical officers. You served as a CMO, then a CEO of St. Vincent's Health in Bridgeport, Connecticut. Do I have that right?
That's right. And then a CCO of a healthcare system in Chicago, Amita Health.
And I did not have the honor of achieving that leadership role. But while you were there as CCO, another thing we have in common is you produced and initiated a leadership development program for physicians. Is that right?
Yep, absolutely.
And now we're both in academic institutions, having served as CMOs and other title roles. And we both have a keen interest in physician leadership development at the medical student level, right?
Yeah. Medical student, I think it's important at all levels. One of the reasons to bring it to the medical student level, which I'm sure you've heard, many physicians, once they start to learn about healthcare administration and physician leadership, one of the first comments is, well, why didn't I learn this in medical school?
That's exactly right. How did you transition from your executive roles into this academic role? What was that all about?
Well, it really came about after COVID. So I had been in Chicago as chief clinical officer of Amita Health, starting in 2016 through COVID. It really was a wonderful time. Even as difficult as COVID was, it was a really interesting time for teams to come together and do some amazing things. What happened was when COVID broke out, and for us, it was January 2020, we actually had the second patient in the country with COVID in Chicago, but it really started to get very bad, like for everyone else, in March of 2020. It was 18 months later, about a year and a half later, when we started breaking down the command centers that we had set up for COVID, and it just felt like it was time for a change. For me personally, it was clear that the organization was starting to get back into normal operations, and I knew that I wasn't going to be able to give what the organization needed, which is probably another 5 to 10 years of chief medical officer leadership. I I have a long background in medical education, and I thought, this is a good time to transition. And so came down here to sunny Florida. Leaving cold Chicago was another bonus. And I found this position with Nova Southeastern University. It's a new school, and which I've also enjoyed. This is actually the second new medical school that I've had the privilege of being part of early on as the school was being stood up.
So again, a couple more things in common. I am at a relatively new school, and after COVID, I looked around at my next step in life and transitioned away from the chief medical officer role. And I truly enjoy being in the educational space. That has been a very personal joy for me. What did you do to spark some of that discussion around physician leadership and leadership development at the medical school? How did you begin to coalesce your thinking, and what have you done in that regard at the medical school?
Sure. Well, it really, what would sparked it was the comment, we should have learned some of this in medical school. And actually now, there is an expectation that students do learn more about healthcare sciences. Actually, one of my students that I was speaking to last week told me that on step one, there were questions about HMOs and PPOs, which actually shocked me, and it wasn't something I've been covering with them. So I had to change my curriculum. But they are expected to know something about healthcare science and how the world works. And it's important because as the healthcare world becomes more and more clinically led, we need physicians with the skill set to help run these organizations. They may not be the one solely running the organization, but I think there's value in learning how to work collaboratively with healthcare administrators, perhaps with MHAs, with nurse executives, because I truly believe that's the way to get things done. So what happened at NSUMD, it was a little easy because it's a new medical school. So there were ways that we could work things into the curriculum. We approached our business school first, and we wanted to work with them. They actually have well, it's not an MHA program, but it's a healthcare oriented MBA program. And the problem with that is they have a longitudinal curriculum where you take courses over a semester, where for senior medical students, as you know, it's month by month. We
Right.
thought that this would be an opportunity for senior students for fourth years. First and second years were just packed, and we certainly couldn't take out the heart or the lungs. We needed those in the curriculum. And then third year was packed with their clerkship rotations. So we set up a fourth year elective. And this is what I think is interesting. The way we went about this, we had this vast field of business healthcare administration and said, well, what are we going to start with in a month course? What can we possibly teach them? How do we start simple enough? And what should they know? And so we surveyed physician executives and healthcare leadership executives, non-physician executives, through an IRB approved survey, which we sent out widely and started to collect responses. We hypothesized that there wouldn't be a lot of difference in what each side thought that fourth year medical students should know. And it turned out there wasn't. It was what you would expect: leadership, communication, interprofessional collaboration, of course, quality and patient safety, a little bit of finance, a little bit about healthcare operations. Those were all in there. Things that really weren't valued highly, at least to teach a fourth year medical student, might be topics like philanthropy, capital investment, facility planning, supply chain. Those were some of the topics that came lower down on their priority list. So from there, we had a sense of what people working in the field thought medical students should learn about it in an introductory course, and we designed a course. And it's an experiential course,
That's right.
um, where we have asked local CEOs and CMOs to host our students in a shadowing experience so that they can see what's happening in real time. And then we would have discussions about it. So each student gets a little different experience depending on what's happening at that particular time. So they'll have the opportunities. We're actually starting with our first student April 28th. and they'll have the opportunities to go to medical executive meetings, quality meetings, peer review meetings, any real meetings that a physician executive would go to, so that they can start getting a feel for what this field is all about.
That is an amazing approach. You performed a rather classic educator um, intervention, which is the needs assessment, and you looked out at people who have been in these experienced roles and said, if you were to teach a class or if you were to decide what students need to know within the survey, so you get a needs assessment. Because if you were to ask the student, they don't know what they don't know yet, even if they're hungry for the knowledge. So, very wise approach, and I applaud the experiential approach. Listen, everything we do outside of the didactic teaching about the heart and the lungs in medical school is experiential. How do you hold the stethoscope? How
Sure.
do you do a neurologic exam and check reflexes? It's an experience. It's a hands-on event, and you get more and more as you go from a standardized patient experience to simulated experience to clinical rotation to participating in surgical and emergency procedures. So putting the students into a living laboratory is lights out as far as I'm concerned. And I think that's very wise. And I'm very excited to hear, and we'll bring you back when you've gotten the experience as to what the students are going through. But I'm going to ask a possible provocative question, and that is, um, do the students end up um, sacrificing another experience? That's part of the question. So let's start with that. Do you believe that they are losing, because this is the criticism, right? I'm leading the question to you, Your Honor. The criticism is that we are taking things away from students when we're giving them an opportunity to learn about health systems science. So, what is your rebuttal to that, I guess you would say?
Actually, something we actually considered. It's a very good point. First of all, it's an elective, so it's not a required rotation. So students have a choice. What I've been finding, I give second year students a couple of lectures on um, healthcare administration, such as what's the various components of the healthcare world, who are the providers, talk about post acute care, community health, insurance, and utilization review, a whole bunch of topics. And the response is overwhelming. I get a number of students coming up to me afterwards, or they email me about how they can learn more about these topics, because there's an innate interest in it. I think personally, I don't think we're sacrificing anything. I think it's vital for physicians to understand how the world of healthcare works, or else or else it's not going to progress as physicians think it should. Physicians are in the perfect spot to help progress healthcare in a direction that they would like to see it go, instead of being told what direction healthcare is going to go into. And the only way that physicians can lead the way is they need to be educated. And if we start them in medical school, something will catch on with some, and they may become tomorrow's healthcare administrative leaders. We need physicians to do more than just take care of patients. As vitally important as that is, physicians can do more and should do more.
Of course, we're kindred spirits, as we've established already, and I agree with that. And I think that what is eminently clear to many of us who are at a different arc in the trajectory of our career is the ecosystem of medicine that you learned in medical school and in training, and the ecosystem that I learned shortly after you was relatively static. I mean, there were a lot of cool things coming, and there were a lot of great innovations. The DeBakey's of the world, learning how to do cardiac surgery that was unheard of right in the 50s and 60s. And by the time the 70s and 80s and 90s came, there were just amazing things. And we could do a heart transplant. But then, and so most of us could keep up with that. But the medical knowledge continues to exponentially increase. So that's part of the challenge. But the ecosystem exponentially changed. And in our rotations, when you and I did a pediatric rotation or worked at the children's hospital as a third year student, and you became a pediatrician shortly thereafter, it wasn't astonishingly different. Today, a young student who chooses to become a pediatrician and goes and works in an employed model may find that what they learned as a student in a general clinic is overwhelmingly different depending on what model they end up in a corporatized employed large clinic model. And I'm just using that example because I think it's a rather straightforward example. I think our students are underprepared for the ecosystem that they go into. And to your point, I agree, not everyone is poised to be a leader, even if you and I want them and you and I believe we need them. So there's got to be a methodology to giving the right amount of exposure to both the ecosystem, the structural challenges within healthcare, and then allow that student, say in their fourth year, to go back and hang out with that CEO again, or another CEO, or a hospital administrator, and really begin to see what's behind the curtain and accelerate their learning, and then maybe go on and become a chief resident and then an advanced degree to take on the leadership responsibility. What are your thoughts on what I've just shared?
I fully agree. The world will change, and it's changing quicker and quicker. From my point of view, when I was I'm a surgeon, and when I was a resident and I began my residency, minimally invasive surgery did not exist.
Mhm.
And during my residency, minimally invasive laparoscopic surgery came around. 10 years later, robotic surgery came around, and now it's standard for minimally invasive and robotic surgeries. Where, as I trained, and certainly when I was a medical student in my early surgical training, those were not things we trained on. They didn't exist. So the world is changing faster and faster.
I think that one of the skills in traditional medical education is um, repeat and repeat and repeat the same skill until you've become a master of the skill. It's kind of like coaching a young person in tennis or golf again and again and again, and adjust the elbow and adjust the stance until you get better and better at it. And in clinical training, that's often what you do again and again in the OR, and seeing some of the unusual things, and you train your mind to adapt to something that maybe you haven't seen before, but you've done it so many different ways that you become automated, and then you have the critical thinking when something unusual happens. We do need to impart to our students to be agile and adaptable, because what they're experiencing today in their third year, for example, by the time they're done in their graduate medical education, 5 to 7 years may have elapsed from the third year until they're an early practitioner. And to your point, a lot of things will have changed. And if we don't help them prepare for that constant change, which is a source of tremendous grief for a lot of people, but I think it's our obligation, maybe our moral obligation, to help them be ready for those changes.
Absolutely. Change is hard.
Yeah.
Change is hard. And there are people who embrace change. And there are people who definitely do not embrace change and fight change.
Yeah.
And maybe that depends on where you are in your career. If you're older, you tend to fight change a little bit more. If you're younger, you tend to embrace change. That makes sense. I think, what I tell my medical students now is that to be a change agent,
Mhm.
that they are in a perfect place, and physician leadership and physician leaders are in a good place to be change agents. They can actually make change happen. And I think this is an important point, and I said it a little earlier, is that physicians need to be empowered to lead the way and make change happen rather than be victims of change.
Yes.
And
And
that's there's been a lot of that over the last decade or two.
and we don't traditionally train the students in change management. One of my favorite colleagues in the Houston area, he gives a really stunning lecture about change management, and he claims that chief medical officers are change agents, and maybe they really are the future transformational officers when it comes to the care delivery by physicians for patients and for systems. Anyway, he gives a wonderful talk about change management and parallels it to And as an oncologist, you can relate. I used liquids and potions. You used hard, cold steel. We both treated cancer patients in our career. Another thing we have in common. But anyway, back to the point. He has an analogy that parallels Elizabeth Kubler-Ross' 5 stages of grief, and the denial and the anger, and then ultimately the bargaining and the depression and the acceptance that comes with change. And as you mentioned, some of us older in our career, we didn't sign up for rapid change. We didn't sign up for minimally invasive, ultimately robotic surgery. And so when you didn't sign up for it, it is a challenge to change, just like you don't sign up for some of the bad things that happen in life, and they inevitably always do. So change management may be a process where you have to address those reactive behaviors, that denial, that bargaining, that sadness, that loss, and finally acceptance. And if you are skilled to take your colleagues, your peers through that journey, you do a better job of it. Have you ever heard of that before?
Well, I haven't heard of it applied to change, but I can perfectly envision it. Um, I think another way to think about it is how do you avoid actually going through those 5 stages, and how can you get upstream and get ahead of it? Change management always starts with the why. Why are we changing? Why does this thing have to change? And what I found is if you start with the why and you explain the why early on, at least not everybody, but many people will understand the need to change and will jump onto the bandwagon a little earlier. There will always be the laggards who who fight and do go through those stages, and if they do change, they're changing very reluctantly. And then there are physicians who decided to retire early because of all the changes that have happened over the last decade or two, and have decided just to exit the field. I mean, I think that's really sad, but it's also the ultimate resistance to changes in healthcare.
Yes, and another element to the departure of physicians may also be back to that exponential element that I described. This is my own thinking anyway. The structures of healthcare delivery require us to work differently than we did in our first few years of our career. And so we do more tasks, we do more activities, we do more trivial items for the care. Now, it may be with the right intention, better quality, better outcomes. We won't argue that on this podcast today, but the quantity of work to be sustainable, to have the type of practice, the income that you seek, is a lot heavier than in the late 80s and early 90s. You could have a reasonable pace, still on call, still get tired, but you're younger and things are a little bit easier to bear at that point. But now we work so much harder on lots of activities and tasks, perhaps for less return on that investment. And I do think as we go through the arc of our life and we age, that is not as easy as it was when you're 35. And by the time you get into your 60s, that is just something that some people just didn't sign up for. And I don't blame them. And I know there's a lot of critics that physicians should stop quiet quitting and should stop retiring. Listen, back to the earlier point, we didn't create this system, and it is a difficult one at a certain point in your career. And that's why physician leaders need to rethink, what does it take to sit down with patients and to care for them and get rid of the things that are managing our time and my resources, my energy level, my concentration, my critical thinking. I need that focused in one direction and once only. So I think, again, we're very much on the same page about
Yeah.
that.
You think about the physician leaders of tomorrow. What are they going to have to focus on? They're going to need to focus on physician shortages. The baby boomers are all growing into their elder years, and the shortage is getting worse. I think that it's about 180,000 physicians short by 2037, which isn't that far away. It's only a little over 10 years away. So to think differently, speaking of change, how do we take care of patients differently perhaps team-based care. We hear a lot about team-based care, but it's going to take physician leaders to bring other physicians along into team-based models because it's not innate to us. Many physicians were taught to be solo, trust nobody, take care of things yourself, and that you're the captain of the ship. Tomorrow's world, especially in primary care, I think is where team-based care really takes hold. In tomorrow's world, we have to be less resistant to advanced practice nurses and physician assistants and physician and provider extenders that are going to be needed to help take care of this large burden of patients and perhaps ease the burden that you were mentioning of all the busy work and all the things and the regulatory things that we have to do on a day-to-day basis.
I have been spending time observing and listening to folks who work in the VA system, and they have advanced that team-based model for many, many years. And I would submit that their outcomes are excellent. The providers, that whole team, are much happier in the care that they deliver because it is a divide and conquer mentality. And I think, it's the largest single health system in the United States is the VA healthcare system, and we could learn a lot from that and begin to produce that. But it will take physicians to sign up for that, like you said, outside of the VA, and that will require some change agents to make that
Yeah.
happen for
The other
sure.
one is AI, which is anybody's guess where that's going to go. But
Yeah.
theoretically, there's the possibility that AI could make us more efficient. Um, I think about scribes. Will there be scribes in another year or two as AI creeps into the offices and is able to transcribe our patient encounters? So there's a lot of things coming down the pike, change that tomorrow's leaders do need, and today's leaders. I'm not even going to say tomorrow's leaders. Today's physician leaders need to address.
Yes, I am a little reluctant to go down the AI trail, but I know it's coming, and it will be on the whole probably a positive. Things that we should be thinking about is if an ambient digital technology like this is recorded, I still have to go back and edit everything we talked about to make sure it was accurate and appropriate. And you don't want to duplicate your work if you can avoid it. But if it does do it accurately, great. Now you've just saved yourself a lot of time. Then the flip side is that somebody else who controls your schedule doesn't throw three more patients into that wonderful moment of time when you could be calling a patient about their CAT scan result or doing something other than seeing more patients with this 45 minutes saved in your day.
Right.
That is alarming to me, and I know that that's how people sell AI for the return on the investment because of the more productivity you can squeeze out of the provider base. I'm a little jaded right now, and we'll have to wait and see how that happens.
So
But I have a
are you
question.
saying that you're reluctant to change?
I am a little reluctant to change, but only a little. I'm in that slight denial, soon to accept category.
Right.
Uh,
And that's appropriate, right? Because you're going to have your change, you're going to have your early adopters, and
right.
that's already starting. And I do have physician friends that are using AI in their office in one aspect or another. Then as a little time goes by and maybe it's improved upon, then other physicians will start to follow. And then, of course, we talked about the laggards who will never adopt it no matter what.
Yeah.
And I'm not neither a proponent of AI nor firmly against AI, but I do feel that AI isn't going anywhere.
Right. It's here.
Yeah.
It's going to be part of our ecosystem, right? And so we have to be thoughtful about it.
Right.
So I want to ask you if you're willing to create a prediction in your mind, and then we're going off script now, but I've been exploring in my own mind, what is the future of doctoring? What will doctoring look like? And what I mean is, so you mentioned the baby boomers, and it's also been referred to as the silver tsunami. There will be a lot of people who are of an advanced age who may still be very, very healthy because of the advancements in care and how people take care of themselves. But while there will be a quantity which will have its own quality, what is the quality of doctoring? What will doctoring look like? How will I doctor to somebody? Because I imagine in 2035, 10 years from now, it won't look like what it was 10 years ago, the act of doctoring. Do you have any ideas on this? Any thoughts on the matter?
I really haven't thought about this, but off the top of my head and direction I hope we do move towards is a preventative health direction where we are focused more on preventing disease than treating disease. Unfortunately, the United States, while we have a wonderful healthcare system, we do not necessarily have the best outcomes. And one reason some people feel that is because we don't do a very good job at um, preventing disease. And so hopefully doctoring will focus more on health and promoting health versus health care, which is sick care, which is what we do now. You know, and the other thing that popped into my head, you mentioned the aging population. There are still diseases out there that we don't have a good handle on. And as we cure or turn many physical diseases into chronic diseases, we deal with diseases of the mind. And I anticipate that we will have a large population of people who are developing dementia, that perhaps don't have the ability to take care of themselves and need help, whether that's home help or they need to be in some type of facility. I think that we're going to see more of that. And those people do require doctoring in addition to nursing care. So I think those are two things. I think the exciting part is the preventative part. The not so exciting part is how are we going to deal with people who are living longer, which is could be problematic.
Yeah, and the middle ground is just as complicated. If you believe that we have reduced the number of severe heart attacks, severe strokes, other major insults to the body, but we get chronic multi-infarct dementia, tiny little infarcts. We get chronic heart damage from tiny little damages to the myocardium, whether they're plaque related or otherwise. And so you have people living with, back to the point about prevention, you have people living with very, very difficult long-term chronic end-stage conditions, but living for a long time, whereas that wasn't the case, say, in the 50s or 60s, where a massive event would take you out of circulation. So it's all about that change. Let's go back to talking about chief medical officer life and physician executive life. When you were at in Chicago or in Connecticut, what, or even today, if you choose, what has been the hardest thing for you personally of being a physician leader, affecting you as a person, as a human being?
Affecting me as a human being. I think I think well it's personally, but it's also professional, is getting out of the mindset of my own specialty. So I think coming into this field, I was in the mindset that I'm a surgeon and everything up to the point of being a chief medical officer was departmental. I was looking out. My first job in administration was chief of surgery at Bellevue Hospital in New York City, and that was about representing the surgeons in the operating room environment. And the committees I sat on early in my career were surgery committees. Everything peer review was surgery peer review. It was always based around surgery. And then all of a sudden, I'm being transitioned into this world where I can't think only about surgery. I have to start to think about other specialties, and sometimes to the detriment of my own specialty. And personally, that was difficult, and it was a difficult transition to really raise yourself up to a 10,000-foot level and look down upon the entire healthcare system that you are now the chief medical officer of, and that your physicians, just like you love all your kids equally, you love all your physicians equally. Um, and that was certainly had an impact. Personally, I've been fortunate. If you take it out of the professional realm, I've had a loving, very supportive wife who's always supported my career. I have two kids who are now, well, they're into their late 20s now, that have always been very supportive. Um, I think all physicians, we've taken personal hits. We certainly have missed events over our lives, but honestly, I think as a healthcare executive versus a surgeon, I probably had a little more control over my schedule, because I didn't have to worry about patients coming into the emergency room at all hours of the day. So maybe my personal life may have even improved a little bit as a healthcare executive. But I guess it all depends where you're starting from.
Yeah, no, well stated. And again, it goes back to that awareness of the ecosystem and moving from that sort of narrow view, or put your hand in front of your face, and as you move your hand out, your view broadens. You get up a little bit. You see, it's not just about one specialty or one discipline or one department. Um, Again, going back to when you were in that executive role, and aside from COVID, which is a hard thing to avoid in any conversation, do you have any recollections of any particular major dumpster fires that you were called upon, that you were able to put out, and that you can recall a skill or two that we want to share with our listeners who hopefully one day want to be a chief medical officer?
Yeah, well, unfortunately, I have a few of those. Yeah,
There you go.
I was well prepared for COVID, and it was because of things I learned with other disasters. I was a chief of surgery at Bellevue on 9/11, and which was probably it was much shorter lived than COVID, but the impact was just as horrendous. Um, and looking back at how we organized ourselves and organized ourselves for really the patients that never came. Very, very sad time, but a very important time for me professionally, where I learned a lot about emergency management. Um, from there, I had been part of some other disasters. But I was in the Northeast, so you always have your storms. Just like here I'm in Florida, we have our hurricanes. But Superstorm Sandy, we had Winter Storm Nemo, and these are events that closed down the healthcare system because people couldn't get to and from work. So these are the events that stand out in my mind. But what they all have in common with COVID is that we stood up emergency command centers. And I think the major tool that is so important for physician leaders to understand is the hospital incident command center. It is sometimes painful to drill on what to do during a disaster drill, but it is so important for physician leaders to understand the command center and to set up a command center structure during these fires that you say. You talk about different styles of leadership: collaborative leadership, servant leadership, dictatorial leadership, whatever it might be. I consider myself a collaborative leader. I think that has served me well. But when you're dealing with these events, that's not the time to be a collaborative leader. That's the time to turn on your decision making and 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 really, think about what's best for the organization and for the people who and for your patients and for the people who represent your organization and your communities, and make sometimes very, very difficult decisions with limited data. So you have to be somewhat comfortable with ambiguity.
Absolutely. And I'm touched that you shared your experience relative to 9/11. For what it's worth, and maybe you were involved at some point, my cousin was severely broken at a different time in the universe, but treated entirely at Bellevue by the trauma service and put him entirely back together. And he's a teacher in Queens. I'm very proud of Bellevue. I visited him there. It's an extraordinary institution with a long history. So you have earned your honorary chief medical officer, fire chief badge,
Wow.
and I'll make sure that you get that badge before too long. The value of learning that leadership is about comfort with ambiguity is the understatement of the day. You have got to be able to flex from being collaborative to decisive and living in ambiguity, because you will not always have all of the information, have all of the answers at the same time, which as physicians we're trained on. You think you're getting into that peritoneum and you think you know what you're going to find, and then you're surprised and it's a little ambiguous and you have to do something. You have a condition that you're not all that familiar with. You heard about it in medical school, and oh, gee, uh, we're going to have to do something here. And I think that as physicians, we are appropriately trained for that, even if we're not trained in emergency management and we haven't gone through hospital incident command training. But we can learn those things. We can quickly adapt and quickly be very skilled in that. And I agree with everything that you said about leadership and the difficulties. Let me give you the closing comment. Is there any other advice you would share with our listeners who hope one day to become a chief medical officer? We train, we do a deep dive in our chief medical officer academy about Hurricane Katrina and other incident command structures. We give the tools to the young physicians to think about. It could happen in your area. It could be a wildfire, it could be a flood, it could be this, it could be that. But any advice you want to give our young listeners?
Well, certainly expect the unexpected. That's very important. My advice would be the advice I received when I became chief medical officer at St. Vincent's of Connecticut. I sat down with the outgoing chief medical officer. I said, if you had one piece of advice for me, what would it be? He said, always get back to your physicians within 24 hours. Even if you don't have an answer, get back to them and tell them you'll get back to them in another 24 hours.
That is such sage advice, and I absolutely agree. And we're going to have to add that into the academy now because we don't have that. That'll be Stuart's rule, and
Yes.
we'll share that with the team. Listen, it has been a real pleasure having you on the show.
Thank you.
It has been remarkable. And being a chief medical officer is no small or easy task, and it takes a lot of intentional preparation, even though a lot of it feels like a trial by fire. My old boss told me it was a lot like a career in firefighting. You start by going to a school, in this instance, firefighting school, maybe medical school, and you train and you drill and you're ready for the fire. You put on the uniform or the white coat. You start out as a fireman or as a medical student. And one day, perhaps somebody says, you're so good, you should be the squad leader or the captain of the house. And maybe you become the chief resident, or the fire chief of the house. Always think you can never be a good fire chief until you're a good firefighter. Do you agree with that sentiment?
I agree. You're not going to wake up one day and be the chief medical officer. You do have to go through those stages. I think from the time I first got into quality work at Bellevue to the time I became chief medical officer was probably close to 12, 14 years. And it's going through all those stages of doing your departmental work first, going through your committees, starting to get involved in hospital-wide committees, maybe medical executive committee, and then ease your way up into more and more progressive roles. And then if the opportunity comes along, take it.
Yeah, totally. Well, you have been listening to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. If you want to learn more about what it's like to be a Chief Medical Officer, if you want to be on the show, email me at leescheinbart@gmail.com or connect with me on LinkedIn. You can listen to the podcast on Apple, and you can also watch the videos of the shows on YouTube. Our show's website is thefirechief.podbean.com. I love talking with CMOs from all over the United States. Please connect with me, leave your reviews and your comments, and please share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.